So it's 12 and shall we start right on time? Okay. First thing is, thank you for those who have taken out time to come and join us. Can you put the slides on the screen, please? Okay. First of all, why do we have this program? This is not a very elaborate course. The entire purpose was to come up with day-to-day problems that all of us face in our ophthalmology clinics. This is what a typical OPD looks like, crowded. Most of these patients would either have a refractive error or a cataract. Some of them would have glaucoma and other problems. Oculoplasty hardly takes up about 5% of your caseload. But the problem is, among some of these would be lurking some of the dangerous ones, the ones that are potentially life-threatening or sight-threatening. So we're talking about tumors, some of them being malignant tumors, and that is the point of this entire exercise. In a busy clinic where you have to see a lot of patients in a short time, it's a risk getting missing some of these. In the morning, we had a free paper session where it turned out that 38% of retinoblastoma patients were being misdiagnosed by the ophthalmologist on the first visit. Now that's a big number because ultimately an early diagnosis is what leads to a situation where you can salvage the eye or you can salvage life. The same problem happens with other tumors as well. So this is a very basic course where we are not going to be talking about treatment in detail, but mainly about recognizing disease, pattern recognition, early diagnosis. So that would be our objective. So my name is ANIRBAN BHADURI. I'm a practicing ocular oncologist. I work in Eastern India in Kolkata. And I'll be talking about eyelid tumors. We have covered the entire spectrum of tumors which are important for the ophthalmologist. And there is a slight change in order. So Dr. Seema Das would be talking about retinoblastoma. That would be followed by Dr. Roshmi Gupta, who is from Bangalore. She works in the Trustwell Hospital. She used to be with Narayan Netralaya for many years, but now she's moved and is practicing in multiple institutions. And from further south, we have Dr. Vikas Menon, who's going to be talking about ocular surface tumors. So without much ado, we'll proceed with the body of the instruction course. So how many of you are movie fans, cowboy movie fans? Raise of hands. We can all come forwards because we want this to be as interactive as possible. And how many of you have seen this particular movie? Okay. Maybe some of you haven't seen the movie, but you've heard the signature music that comes with it, where there's a coyote calling in the background. Now, I've been a movie fan all my life, and this is one of my favorite movies. I remember bunking college to go and see this in a hall. But why I chose this as a topic was because these three characters in the movie define exactly what we do when we see tumors. So you have the good, you have the bad, and then you have the ugly ones as well. But if you have seen the movie, you will realize that they all are not clean black and white characters. They all have shades of gray. I hope we'll be able to bring this out in the course of this particular instruction course. So what are we actually looking at? What are we really interested in? We need to take certain management decisions, right? First of all, the most important step, of course, being what is the disease? And then, if you're not sure about what is the disease, at least what is the nature of the disease? Is it good? Is it bad? Or is it just ugly and not as bad as it sounds? The next very important decision that needs to be taken is what is the extent of the disease? Okay, because that is also going to affect your management decisions. Finally, once you have the answers to the first three questions, would you decide how would you manage it? Now, some of these are situations which you can manage in your own clinic, in your own institution, and in certain other situations, you can take a decision to refer to the nearest available person who specializes in treating such conditions. Okay, look at the good ones. Why do we say the good ones? Because they will not kill you, or they will not kill your patient. So we look at certain cystic masses. Now, this is very common, right? An acrine cyst of Moll, and this typically is whitish or slightly yellowish, doesn't transilluminate very well because of the nature of the contents of the cyst, arise in the lid margin. But this is another one which is bluish, translucent, it transilluminates, and sometimes you will also see a bluish deposit at the bottom or sediments at the bottom. Now that's an apocrine cyst. Now these are both sweat gland cysts and they are benign. Look at these multiple cysts which also arise from sweat glands, which are syringomas. And this is a common condition which because of blocked sweat glands, which is known as milia, which is often seen in heart condition. Now, all of these are benign conditions. All of them are cystic lesions. Okay. This used to be earlier known as a sebaceous cyst, typically identified by this punctum that you see on the top of the cyst, arises from sebaceous glands, or actually sebaceous gland around a hair follicle, which is why you get that punctum. Okay, let's look at solid lesions. Now, this is a slightly unusual presentation of a very common condition. This. What do you think is it? Common inflammatory condition of the eyelid. So this is actually a very large chalazion. Okay. So you evert it and you can see the swelling is more prominent on the posterior side of the eyelid. This pale, non-pigmented lesion with distorted lashes arising from the lid margin. The distorted lashes are important, number one. And number two is these lashes are often hypertrophic. It's been there since childhood and has been growing gradually. Common lesion. What is uncommon is the color. So that's a margin nevus. Okay. Why is it different? Is because it is not pigmented. This is a spot diagnosis, right? This is a 3-month-old child, a rapidly growing lesion, a capillary hemangioma. This has a surface. Look at this solid lesion. This is an elderly patient. It's a solid lesion which has a surface which is very similar to a walnut. And you know what the surface of the walnut looks like? It matches one of the structures which is there within our protective cranial cavity, right? So it's a cerebriform surface. This is typical of a seborrheic keratosis. Seborrheic keratosis can also have a papillary surface which weeps, which looks unhealthy. But this is one of the forms of seborrheic keratosis. All of these are benign lesions. What would you do with benign lesions? So benign lesions can be excised in toto. All right, your excision would be limited to the location of the lesion. All right, this is something that is often mistaken to be a chalazion. This is a tarsal cyst. Okay, let's look at some of the bad ones. These. Any answers to this? So it's arising from the lid margin. Part of it is pigmented, part of it is shiny, pale. Louder. Louder, please. Purban, I'm waiting for your answer because I can hear you saying it. I'm a little hard of hearing. So this is a small nodular basal cell carcinoma. Okay. Okay, what is this? rolled margins, central ulceration. This is also basal cell carcinoma, but this is nodular ulcerative variant. But this is the marking which we will refer to very soon. You see the marking beyond the lesion. Okay. Okay. A larger one. So part of it is pigmented, part of it is not. But this is again a nodular ulcerative basal cell carcinoma. This is more subtle, more diffuse, not a typical nodular or an ulcerative lesion. This is the morphia form variant, and this is the worst kind. So because this can infiltrate under the skin and go beyond what is apparently visible on the surface. Okay, so all of these were basal cell carcinomas, which are apparently the commonest tumors in the West. In our country, it more or less matches the next tumor that we're going to discuss about. Okay, so pearly lesion like the early one, and larger lesions would have the rolled edges. These are all locally destructive. They hardly ever metastasize. Okay, but they could invade the orbit, they could destroy bone if you leave it unattended. This is our other tumor, more common among Asians like us, and it has a typical color. It is yellowish. And as Sir says, this is the sebaceous gland carcinoma. Okay. Let's see some more sebaceous gland carcinomas. Look at this lesion. You can see this nodular swelling here. If this was not there, you would probably think it is a chalazion, which is why every time you see an eyelid lesion, always evert. Then only you will get to see the true picture. And you see this is the nodular component of the tumor. There is also a flat papillary component which is extending way beyond the nodular lesion that you're seeing. And that is pagetoid spread, which is very typical of a sebaceous gland carcinoma. So your excision is going to be even beyond that. Right? This is a more destructive lesion. So you see the tumors in the upper lid, destruction of the lower lid. There are also small nodules on the conjunctiva as well as on the limbus. And this patient also had involvement of the lacrimal sac. Because like you have pagetoid spread, you could also have something called onchoria, where tumor cells actually flow with your tears and enter the lacrimal drainage system. It's something to watch out for. Okay. So these are all sebaceous gland carcinomas, and what is important is the color. Okay. And the location. Let's see this one. This is more diffuse. And although it has this whitish appearance which seems to look like keratin, this is not OSSN, this is sebaceous gland carcinoma. This is the typical pagetoid variant. You don't see a single nodular lesion here, except you see thickening of the lid margin. In some areas you also see what? Lack of eyelashes. So there's been destruction of the hair follicles. Right? So here we have a mix of lesions, some of them benign, some of them malignant. Now what distinguishes malignant from benign? So these 3 points: the loss of eyelashes, telangiectatic vessels over the lesion, and thickening or distortion of the lid margin. All right, if you can remember these 3, you more or less know whether you're dealing with a malignant or a benign lesion. Let's look at this patient. This was diagnosed by a colleague who works in one of the districts far from Calcutta where I work, right? And this is a doctor's wife. And she was referred for this inflammation that is there in the lid margin, which was not going away with steroids. So she'd been seeing multiple doctors until she reached this gentleman who also practices pediatric ophthalmology. So he felt there was something suspicious. Now here you don't see destruction of the lashes, but there is a thickening of the lid margin, and there is the same whitish appearance that you were seeing in the previous case. And we did an incisional biopsy, so this is what is happening with the lid everted. This is probably an extent of pagetoid spread. Is my time over? I have only 1 minute. Okay, I think we should rush. Sorry, my fault. Okay, my introduction, 5 minutes. Yeah. So in a malignant tumor, this is how you would change your strategy. You would go beyond the visible tumor margin. So you do a wide excision. You also want margin control so that you know whether your excised margin is free of tumor. If you have frozen section control, great. Otherwise, you can ask your pathologist to expedite the examination of the margins and then go ahead and do the eyelid reconstruction. In sebaceous gland carcinoma, additionally, we would also do conjunctival map biopsies. Okay, so each biopsy is put on a filter paper, marked, and you would maintain that map with you in your records and then wait for the reports to come. If there is pituitary extension, then you would either have to do cryotherapy to those areas or add mitomycin C drops. Okay, there are certain situations where you cannot do an excisional biopsy. Like this tumor, we do not know what it is. So to able to make a diagnosis, you would do an incisional biopsy. This turned out to be a Merkel cell carcinoma. Look at this other lesion. Large swelling, mostly on the posterior surface of the eyelid. This was a lymphoma, a diffuse large B-cell lymphoma. This is that patient where we wanted to do destructive surgery simply because there was no way we could salvage the eye. But you need a histopathological diagnosis before you go for it, right? Before you do a destructive surgery. So there again, you need an incisional biopsy. Here, we were not actually sure of the diagnosis, which is why we did an incisional biopsy. We had a suspicion, but we needed proof. Okay, now look at some situations where you don't know what it is. So this crater-like lesion, a keratoacanthoma, this could be malignant. Okay, this is the common situation that we see. You see a skin tag, but at the base of this, you could have a malignancy. So these are situations where you excise the entire base and you look for the pathology in the base. These may be benign, but they could also be malignant. Okay, this is the gentleman who has multiple lesions on the eyelid. See, 1, 2, 3. 3 different pathologies in the same. So that could happen to your patient as well, right? Okay, these are the ugly ones. 2 minutes? Ugly one. Look at this ugly looking thing here. This is the benign condition. This patient has a seborrheic keratosis. But how would you prove it? You need to excise, right? Look at this other one. Ugly lesion that has been there for a year. This is what happens when you evert the lid. There is actually a normal lid underlying that pedunculated mass. And this was a very large papilloma. Again, a benign lesion, but we were not sure. We thought it could be a squamous cell carcinoma. Okay, my last ones. So you have these pigmented lesions in the eyelid. These are not meant to be excised, but the reason why we are showing you these slides is because there could be underlying disease that we need to be aware of. And as ophthalmologists, it's our duty to keep doing our dilated fundus examination for these patients for the rest of their lives. Okay. You know what is this? Sturge-Weber syndrome. The tumor that you're looking for is a diffuse hemangioma of the choroid. All right. This is oculodermal melanocytosis, otherwise known as the nevus of aorta. And what is the tumor that you're looking for? Is uveal melanomas. Okay. What is this? I'll tell you what is the diagnosis from outside. It's a plexiform neurofibroma. But what is the associated syndrome? Is neurofibromatosis type 1. Look at this child. There are patches of abnormal skin here where there is no hair growth. Okay, along with these abnormal looking chorostomas. I think we'll skip it. Last, what are these lesions? I'll give you a hint, they are umbilicated. Molluscum, right? Now look at this kid. Mollusca, large mollusca. Several of them. Is there something that you need to suspect? This child is 2 years old. He turned out to be HIV positive. Okay, I'll stop here. So we'll do questions at the end of all 4